Hello, my name is Young Sik Woo, Assistant Professor at Hallym University, College of Medicine in Seoul, South Korea. On behalf of the author, I would like to thank GI Endoscopy Editorial for the opportunity to address further about our article entitled Efficacy of EUS and ERCP-guided biliary drainage for the malignant biliary obstruction, prospective randomized controlled study. The standard palliative treatment of malignant distal biliary obstruction is an ERCP-guided biliary drainage, an endoscope insertion of metal stent. However, for some cases, including a proximal obstruction or altered anatomy due to previous surgeries, in which we cannot perform endoscopic drainage, only PTBD was the alternative method. PTBD has a higher risk of adverse event and worsens the patient's quality of life because it's an external drainage. Recently, US-guided biliary drainage has emerged as a rescue technique after failed ERCP. USBD has been developed and performed by experienced endoscopists with reports that it could be performed safely. USBD has several advantages. First, USBD makes no impairment of QOL of patient, unlikely PTBD, because it's an internal drainage like ERCP-BD. Second, USBD potentially avoids the stent restenosis by a tumor ingrowth, unlikely USBD, because stent is inserted bypassing tumor mass like PTBD. Third, the risk of post-procedural pancreatitis in ERCP-BD can be avoided due to no risk of manipulating the pancreatic duct or orifice. In addition to this, it can be performed directly after failed ERCP in same session by same endoscopist. USBD was a technically challenging procedure in the beginning, but the progression and development device, endoscope, and techniques makes it easier and safer. Considering this aspect, we assume that USBD can be the initial choice of palliative treatment for all malignant distal biliary obstruction. To evaluate this hypothesis, we conducted a randomized trial to compare USBD and ERCP-BD for primary biliary decompression in the malignant biliary obstruction. Our study showed the success rate, stent patency, and adverse event of both procedures was similar. We confirmed that USBD procedure is technically feasible and can be safely performed compared with conventional ERCP-BD. The cause of stent dysfunction were quite different between this group. The major cause of stent dysfunction in ERCP-BD was a tumor ingrowth that required additional stent insertion. On the other hand, USBD had stent dysfunction because of food infection and stent migration. The food infection was successfully managed with sweeping food with a balloon catheter. Pulling the infected food material from the inside of the stent. Interestingly, two patients had stent migration. No additional procedure was required because the spontaneous development of permanent biliary enteric fistula at stent site. Practically, we have not directly compared technical points because it was hard to quantify and needed a very large number of patients. Rescue USBD after failed ERCP-BD is considered a more difficult procedure than ERCP-BD because ERCP is more familiar than US. In addition, there are a few reasons of this difficulty. It is more difficult to keep the endoscope stable in the duodenal bulb during USBD than to keep it stable in duodenal circumposition during the ERCP-BD. ERCP-BD failed mostly due to anatomical variation, then make the endoscope manipulation of USBD more difficult. bile juice may leak into the peritoneal space from a initial needle puncture to stent development during USBD. It causes abdominal pain of the patient, then leads to an irritable of the patient. It often failed the procedure. The single-step device and the luminal opposing metal stent have been developed for USBD. They are likely to decrease the bile leak by simplifying the procedure and shortening the procedural step. Comparing the risk USBD, primary USBD can be technically easier because an endoscopist can be placed endoscope with an anatomical limitation more often seen in the rescue USBD. So stent can be inserted in the best position of the endoscope to find the ideal access route for USBD. USBD, an immersion technique, is considered as a better alternative method for PTBD after failed ERCP. I think our study provides the first evidence to expand the role of USBD to the first-line biliary drainage instead of ERCP-BD. However, this study was conducted with a relatively small number of patients at single tertiary center by expert endoscopists with significant ERCP-US skill. Hence, the result may be limited to be widely application. We will look forward to have our result validated in larger study. Thank you very much for your attention.